Hello people, in this video let us look at all the causes of metabolic acidosis. Okay, metabolic acidosis causes list we want to look at. First of all, what is acidosis? Acidosis means pH is lower than 7.35. That is acidosis. Now what is metabolic acidosis? Okay, metabolic acidosis means acid is more. So which acid is more? So acid you can say is more. So which acid is more? Any acid other than carbonic acid. Okay, any acid is more, but not because of carbon dioxide accumulation in the body. You got it, people? So say what is metabolic acidosis? The pH is low, so the acidity is occurring because of any acid other than the carbonic acid, which is due to carbon dioxide retention. So here what exactly is happening is the HCO3 minus, that is the bicarbonate ion, right? This one is going to be low. So there is a fall in plasma bicarbonate. So that is metabolic acidosis. Okay. So in metabolic acidosis, people, there are two types. Okay, one is where there is increased anion gap. Okay, increased anion gap. Okay, and then another one is normal anion gap. Okay. So increased anion gap and normal anion gap. So first of all, what is anion gap? You should know. Anion gap means the difference between the positive and the negative ions that we measure. It is not between all of the positive and negative. All of positive and negative will anyways be balanced. Okay, but only the ones that we measure, those positive and negative, between them there is a gap which is always there. That is normally 5 to 11 millimoles per liter. Okay, so this gap is 5 to 11 millimoles per liter. This is given by Davidson textbook. So please pay attention here. Between the cations and the anions, the gap is 5 to 11 millimoles per liter. This is the anion gap. So which are the cations they are considering? Mainly sodium, and anions they are considering are chlorine and bicarbonate ion. Okay. So between these two you have something called as an anion gap, which normally you will have 5 to 11. That is what Davidson says. So this gap, if this gap increases, okay, this gap increases. So let's go back to that image there. This gap has to increase. So if this gap has to increase, that means to say this acid will increase, right? So that time this gap will increase. Correct? So if this increased anion gap means what? Acids have to increase. So from where are the acids coming? Okay. So one thing is your body itself is producing more acid. Okay. So body itself is producing more acid, or it is not able to get rid of acid. Okay. That can be happening in kidney disease. So in kidney disease, especially what happens, there is accumulation of organic acids. Okay, then diabetic ketoacidosis, starvation ketosis, alcoholic ketoacidosis, lactic acidosis, where lactate accumulates, right? Diabetic ketoacidosis, ketones are accumulating with hyperglycemia. Starvation and alcoholic acidosis, accumulation of ketones without hyperglycemia. Then lactate, why will lactate accumulate? Because of some anaerobic metabolism, excess muscle, but mainly you should remember shock liver disease, some drugs which you are taking like metformin along with kidney disease if they are taking metformin, or there's some poisoning which has happened which can lead to lactate. Okay, so those all these can lead to increased acid endogenous production. Okay, so did you understand, people? Where are we? We are in metabolic acidosis. In metabolic acidosis, there are two types. One is where there's increased anion gap, and there is one more is anion gap is normal. Okay, so first of all, in increased anion gap, we saw that acids are more. From where did the acid comes? One is the endogenous acids. From where and all you saw? Four things. Ketones, yes, in diabetic, and then in starvation, and then in alcohol. Then you saw lactate. Then you saw one more was there, kidney disease, where you have acid accumulation, right? So these are all increased anion gap, endogenous acid production. Okay, then one more thing is exogenous. Now we are coming to this part of it. In increased anion gap itself, you're taking acids from outside, like you're taking salicylic acid, right? Aspirin, poisoning, too much of aspirin, methanol poisoning, right? Where formate will accumulate. Or if somebody has drunk some antifreeze poisoning, that is ethylene glycol, where oxalic acid, is it? Glycolate, all these will accumulate. So you're taking the acid from outside. So again, this is metabolic acidosis where there's increased anion gap. Okay. So this is very easy to understand, right? Now let us go to the next one where it is normal anion gap. This may be a little difficult to understand. Normal anion gap. That means this gap remains the same. So what happens is, if gap remains the same, but bicarbonate has to reduce, remember that they have told as a definition, right? So bicarbonate will reduce means what? Chlorine will increase, right? Cl minus will increase, and along with it, this HCO3 minus will reduce. Okay, HCO3 minus 3 has to reduce, you understood, right? That is the definition. So now when will this happen? Normal anion gap, metabolic acidosis. So this will happen when you're taking some infusion of inorganic acid like ammonium chloride, hydrogen chloride. Okay, so chloride is coming in and bicarbonate is automatically getting reduced, obviously because you're taking in an acid. When gastrointestinal loss in diarrhea and all, what is happening? You're losing bicarbonate. Okay, and in urine, renal tubular acidosis, this is RTA. This is a very important term you should know. RTA, renal tubular acidosis. Again, there is loss of bicarbonate. Okay, so you should know this. Guys, this RTA is there, no? Renal tubular acidosis. This itself is a very huge topic. Okay, so basically what happens? Your kidney. So let's draw a kidney here. There is acidosis because of the renal tubules. Tubules means what? So you have to go back. Glomerulus, proximal convoluted tubule. Then you have your Henle's loop. Then you have the distal convoluted tubule, right? So tubular acidosis. So here what happens? The loss of bicarbonate ions are happening. Correct, guys? Focus. So what is happening? You're losing bicarbonate ions. Why? Because this is not able to reabsorb the HCO3. So what happens here? It gets filtered. When it gets filtered, right? So it gets filtered. So it is entering the tubule. HCO3 minus. So this HCO3 minus is going to traverse here. So the tubules were supposed to absorb it back into the body. That's why it is called as a reabsorption. But reabsorption is not happening where? They are blaming the proximal convoluted tubule. They are blaming whom? Let me put a red here. Proximal convoluted tubule is being blamed. PCT. Okay. So this is one thing. The other is impaired acid secretion in the late distal tubule. So what acid has to be secreted into the tubule, that is also not getting secreted. So acid has to get secreted right into this. That is also not happening in the distal tubule or the cortical collecting duct. Okay, intercalated cells. So basically this is another problem in the distal convoluted tubule. Some problem, RTA. Okay, so tubular problem. There can be one more problem, people, that is in the distal. In the distal, so this is the Henle's loop, let's say in the distal one, what happens in the distal, that is the late distal tubule or the cortical collecting duct, there is impaired sodium reabsorption. So you're losing sodium, I'm thinking. So sodium is there in the tube and it is not being reabsorbed. You're not reabsorbing sodium. So impaired sodium reabsorption. Okay. So what will happen? Reduce secretion of both potassium and hydrogen ions. So what will happen? You will retain hydrogen and potassium in the body. So what will happen if hydrogen and potassium are retained? You will have acidity. Okay. So sodium, you are going to lose the sodium and you are going to keep the hydrogen and potassium ions. Okay, there is reduced secretion of hydrogen potassium ions. So this is nothing but hyperkalemic distal RTA. This RTA itself, guys, has so many more further points in it. Okay, renal tubular acidosis, why does it happen? You need to know this. So when PCT, the proximal renal tubular acidosis, is there, it is called as type 2 RTA. It can happen because of, look at this, it can happen because of, focus here people, inherited Fanconi syndrome, cystinosis, Wilson's disease, all the copper accumulation, Paraproteinemia like myeloma, amyloidosis. You know that these are also abnormal proteins, amyloidosis. Then heavy metal toxicity like lead, cadmium, mercury poisoning. So remember, you're talking about the proximal convoluted tubule, lead, mercury, cadmium, mercury. Drugs like carbonic anhydrase inhibitors. Give some example. Carbonic anhydrase inhibitor like acetazolamide, etc. Right? Then ifosfamide, primary hyperparathyroidism. May blame the parathyroid. Okay, here primary hyperparathyroidism. Okay. Then coming to the distal renal tubular acidosis. So people, we are moving on to the distal. Okay, distal part. So focus here. Distal renal tubular acidosis. So what and all are they saying? Again, inherited, but they didn't say what the problem is. Okay. Then autoimmune diseases like systemic lupus erythematosus, SLE, Sjogren's syndrome, hyperglobinemia. What am I saying? Hyperglobinemia. Then primary hyperparathyroidism, toxins and drugs like toluene, lithium, amphotericin. Okay, amphotericin is what? Antifungal, right? Just remember, in PCT and DCT both they blamed parathyroid. Okay, parathyroid, both the places they have blamed. Okay. Now coming to the distal renal tubular acidosis, in this there that hyperkalemia, which I already told you, right? So what is happening here? Why does that happen? That it will not reabsorb sodium and it will start retaining potassium and hydrogen, H+, because of hypoaldosteronism. Okay. Then obstructive nephropathy, renal transplant rejection, drugs like amiloride and spironolactone. Anyways, this one is potassium sparing only, right? What is amiloride? Amiloride also is supposed to do the same thing. Diuretic, we should not lose much potassium. So similar, obviously, so it will hyperkalemic only it will become, right? So in this video, you wanted to look at the causes of metabolic acidosis, all the causes we have given you, okay? So remember, in this metabolic acidosis, H+ will be more, HCO3 minus, this will be very less, okay, less than 24, something like that they are telling. Guys, you know, to know whether it is RTA, that is renal tubular acidosis. So what they are saying, it is normal anion gap, right? So they are saying that there will be more chlorine, hyperchloremic acidosis in RTA. Okay. It can be hyperchloremic acidosis with normal anion gap. We told you, right? In the absence of gastrointestinal disturbance, all that will tell you about RTA. RTA means not road traffic accident, renal tubular acidosis. Remember. Okay. So you will have to check the urine pH. Then you will also have to check the plasma bicarbonate concentration. Then you will have to do some, test where you will give some challenge. Challenge of what? Acid challenge. See, in this video, we are not telling you how to differentiate and all that, but we are telling you just the causes of the what? Metabolic acidosis. Okay. Say bye. Bye bye.